Hello, this is just a quick cannulation reference guide. I'll be pausing, so there'll be some silences just so if people are running through this video and want to read the slide rather than listening, they'll be able to do that. There's no quick way to decide VV versus VA, so see additional ECMO talk if you want to find that information. We're going to go through the cannulas and quick technique. This is the Medtronic Biomedicus, which is what we have for VA ECMO here in Milwaukee. There's drainage and return cannulas with sizes between 9 and 29 French. The return cannulas don't have side holes, the drainage ones do, which can be important when you're removing the cannulas to make sure that you're not cinching down a tie until the cannula is fully withdrawn, because you can get caught in one of the side holes and end up with the tip in the vein and a side hole out, losing a lot of blood. This is a chart for those cannulas, assuming 100 cc's per kilogram per minute of flow, what patient weight and what cannula would give you that flow. I'm just going to pause for a couple seconds in case someone is trying to find this on the video, scrolling back and forth. Here is the same chart, but for patients greater than 30 kilograms. Again, I'll just pause here for a second in case someone's looking at it. Quick technique overview of the VA ECMO cannulation. First step is to make a transverse incision 1 and 2 finger breadths above the clavicle, and then combination of blunt, or if it's a thicker neck, you could use some electrocautery, but anyway, dissect anterior to the sternocleidomastoid. You could also go through or posterior to it. My preferred is to go anterior. Isolate the jugular vein and artery, make sure you're sparing the vagus nerve from your dissection. Make sure you dissect posterior to the vessels so that the ties, when they slip superior or inferior, you can get enough distance. Then go ahead and heparinize. Your institution will have its own weight. Some people max out as well at some number of thousands of units. Place 1 2-0 tie as cephalad as possible, 2 caudally. After you've had 2 minutes of heparinization, go ahead and ligate that cephalad vessel, partially transect it by sticking an 11 blade. Usually I'll do that parallel to the vessel, halfway through it, and then rotate the knife towards the sky and go up. That ensures that you leave a nice back wall to stop the vessels from retracting. Then place the cannulas in. How far? Rough estimate will be that the arterial or return cannula goes 1/3 of the way from the incision down to the xiphoid, and the venous cannula goes half the way to the xiphoid. In a full-term infant, the arterial cannula goes in less than you think, 2.5 to 4 centimeters or so for the arterial return cannula, and 7 to 9 centimeters for the venous cannula. Some people say it's hard to place the arterial cannula too shallow or the venous cannula too deep. Secure those distal ties over a bumper, a little like 1 centimeter section of vessel loop, which makes taking them off later easier. Then go ahead, go on pump and close your skin, usually with a running suture. Placement, if you're having the old Biomedicus cannulas, there's a tip at the end, so don't be fooled and think that your cannula ends there when it actually ends here. The new next gen Biomedicus cannulas have wiring enforced all the way to the tip. Moving on to options for VV ECMO, this is your Crescent RA cannula and what comes in the kit. The cannula sizes are 13 to 19 French and are generally used for below 10 kilos. And after that, you might be switching to the Crescent bicaval or Avalon Elite bicaval. This kit comes with 2 options for vein introduction: an obturator for a cut-down technique or an introducer, which you'll see in this picture here, as well as the appropriate wire, which also comes in the kit, but if you need to get another one if it falls out or something, is listed at the bottom of this slide. Take that stylet, put it into either the operator or the introducer, whichever you're using, and then remove the stylet. That gets your catheter set up. Quick overview of how to get the cannula in. You have one option, which I tend to use in smaller infants because the jugular vein is fragile, and if a percutaneous stick messes it up, it's hard to recover the cannulation process. So I usually go with either option 1 or a hybrid approach, but a cut down similar to what we just described for VA ECMO. Isolate the jugular vein, heparinize, ligate it with your cephalod tie, and then do a partial transection, direct entry with the operator under real-time echo guidance to get it into the right spot in the heart and make sure you're not going too far, and then go on pump, secure catheter, and close the skin. If you are doing it percutaneously, get wire access to the SVC, heparinize, and then dilate, and then again catheter placement under that real-time echo and secure the catheter. This hybrid technique that I'm talking about is if this is your neck incision, doing a needle poke here and then entering confirm placement. If you haven't done that with echo, this is what it looks like on an x-ray. You'll see these 3 dots here making this little L shape, which means that the reinfusion point is pointed anteriorly, and then they really don't want you to place sutures along the wire reinforced parts. They want you to put it on one of these places here, which I've drawn arrows to. Pause here for a couple seconds in case someone is looking at this slide. This is the Avalon Elite in these sizes, where in 10 kilos is typically placed percutaneously. Similar to the Crest RA and other cannulas, the return limb is positioned anteriorly like this, and that ensures that the reinfusion port is directed anteriorly into the right heart. Pause a couple seconds so people can look for this weight chart if they need it. Here's what it looks like on x-ray. You can't see the diaphragm very well, but it's kind of there. And these drainage holes are near that hepatic vein IVC confluence for the bicaval cannulas. Medtronic is really pretty similar to that. It has some different markers on it. These. Just pause here for 20 more seconds in case someone's looking at that. And then if you're using these bicaval cannulas, usually this will be under fluoro guidance, which most people think is the safest way, although others are using echo or x-ray. The reason that we want fluoro is that the initial wire entry is a longer wire and usually a super stiff wire to accommodate the larger dilators. And you want to make sure it's placed into the IVC as far as possible, try to send it almost to the legs or the, and that way you're ensuring that when your dilators and your catheter pass that you're not going to perforate the heart. Once you have that wire, go ahead and heparinize, do serial dilations again with these bigger cannulas. Make sure that the wire freely moves and that you're not placing excessive force, which can bend the wire, kink the wire into the subcutaneous tissue. Once you have a wire kink, it's really hard to pass subsequent steps, and then you almost need to get a new stick, a new wire, which can be very annoying to do, especially if you've already dilated and there's blood everywhere. Once you have that, place the catheter, go on pump. Echo confirmation at the end of placement to confirm the infusion flow direction and secure the catheter. We talked about the major flows, pitfalls already.